Hi, this is Tracy Chu, your fall prevention lead at Sutter Medical Center. Despite our best efforts, preventable patient falls continue to occur in our facility. We convened a task force at the end of 2021 to review best practices regarding fall prevention and make recommendations to guide our policy to keep our patients safe. For the next few minutes, I will explain our policy changes, including a patient scenario for review. We use multiple fall risk screening tools at Sutter Medical Center. Continue to use the appropriate tool for your patient population. As you know, fall prevention starts with screening our patients for risk. We do this at ED triage, upon admission, every shift assessment, upon transfer to another unit, and also, very importantly, we rescreen our patients after a fall. Our risk screening tool helps guide our next steps to help prevent our patients from falling. As a task force, we added a third risk category to our policy, which we will review in the next few slides. If your patient does not screen in as a fall risk, maintain universal precautions to keep your patient safe. This includes creating a safe, unobstructed environment with the call light and personal items within reach, appropriate education for fall prevention, non-skid socks, all beds in low position with wheels locked, and purposeful rounding. For at-risk patients identified by your unit's risk screening tool, we maintain universal precautions and add interventions tailored to the patient's particular risk factors, such as placing the fall risk tab on their armband, instituting and following the fall care plan, educating the patient or parents, if appropriate, to ask for help prior to getting out of or back to bed or crib, escorting those with an unsteady gait to the bathroom, and other interventions as appropriate. For those units utilizing the CPM Adult Fall Risk Screening Tool and Cummings Fall Scale, a high-risk category has been added. This category includes any patient that has been identified at risk, has fallen during this hospitalization, and/or has a cognitive deficit as defined by a patient who demonstrates non-adherence with fall precautions, shows impulsivity, and/or lacks safety awareness. These patients are to have universal and at-risk interventions implemented, as well as other interventions at all times, such as a sensor alarm for the chair and bed for adults, and be accompanied to and from the bathroom with standby assistance. Assess the need for further interventions as outlined above in bold. Let's look at a patient scenario. Mr. Johnson is a 70-year-old gentleman who presented with pneumonia 5 days ago. Over time, he has gotten progressively weaker and increasingly confused. As you can see, his fall risk score has increased over the previous days. Yesterday, he scored at risk due to being a male, his age, and weakness. Today, he is considered a high risk as he also has a cognitive deficit as previously defined. You are concerned that he lacks the cognitive ability to follow safety instructions. What will we do for this gentleman? Let's look at the many tools we have available to help patients like Mr. Johnson. We now have a low, at-risk, and high-risk fall signs to place at the head of the bed in the Med-Surg tele areas. Pediatric areas will engage the fall precautions tab located outside of the patient room. The bed and chair sensors should be utilized for any patient that is now defined as high risk on the adult Med-Surg areas. This alarm, when also plugged into the head wall to be utilized with the call system, is much more sensitive than a bed alarm alone. Is your patient trying to get out of bed or chair against your advice? The Head Start sensor alarm belt for the bed or chair can be utilized to also notify you quickly when the patient is trying to mobilize. Fall mats have been added to the floor inventories. These can be utilized to prevent patient injury during a fall. Their use has to be balanced with staff safety, as staff can slip or trip on these. Staff should not ever step on these. Rather, they should be folded up and stored when a staff member is working next to the patient bed. We now have a low bed stored in the basement of OC Adams at all times. Utilized with a fall mat, a patient that falls out of bed is much less likely to be injured. So let's return to Mr. Johnson. To keep this gentleman safe, we will place the high-risk sign above his bed and outside of his door. We will use the sensor pad plugged into the call bell system while he is in bed or in a chair as indicated by the high-risk guidelines. We will accompany him to the bathroom or commode and provide standby assistance.
Notice that the nurse verifies that the call light system is plugged into the POSI alarm system. She verifies that it's turned on and that the green light is blinking.
If we are concerned that Mr. Johnson will climb out of bed and injure himself, we can utilize the sensor alarm belt and also obtain a low bed with a fall mat for injury prevention. So what do you do if your patient falls? Call a swarm on your unit and assess the patient for injuries. Utilize lift equipment if necessary to help the patient safely get back to bed. Complete a neuro assessment if the patient hit their head or if head trauma cannot be ruled out. As a team, complete the required documentation, PSR, and notifications. Pull the post-fall checklist from the Forms tab on the intranet or your unit to help guide you complete all required documentation. Did you know that patient falls are a common area of nursing liability? We review the chart documentation for every patient fall, searching for improvement opportunities, and have noticed significant gaps in our fall documentation. Evidence-based interventions and complete and thorough documentation can help protect you in the future. For any fall, complete all fields in the significant event area of the flow sheet and a note in the chart detailing what happened if witnessed or what happened as reported by the patient if unwitnessed. Make sure to document your post-fall assessments, fall interventions pre and post, fall risk score pre and post fall, physician notification, family notification if appropriate, and supervisor notification if the patient was injured or required imaging. Complete a PSR before the end of the shift. Finally, best practices in fall management recommend a fall debrief that includes all staff members caring for the patient and family if appropriate. The goal of the fall debrief is to get to the root cause of the fall and obtain ideas to prevent the fall from occurring again in the future. The debrief should be led by the charge or primary nurse. A script will be provided to the units and will also be kept on the form site. An abbreviated form will be turned in to the unit director before the end of the shift. We would like to thank the Fall Task Force for helping to guide the development of this new policy. Our goal is, and always has been, to keep our patients safe by preventing patient falls and injuries related to falls. Special thanks to Jason DeVera and Carla Rodriguez from Neuro for helping with this video.